Today I'm going to be talking to you about interventional oncology, tumor-directed treatment without incisions. Now, just to give you a little bit of background for those of you who may not have come across an interventional radiologist, the word interventional radiology really gives a lot of confusion for people, and I think it's the word radiologist in there. Most people have never met a radiologist. We think of the radiologist as reading your X-ray, your CAT scan, or your MRI. And interventional radiology really is a subspecialty of radiology that focuses on minimally invasive treatments. I'm sure many of you in this room have know or have heard of someone having a heart catheterization and a angioplasty or a stent in their heart. That procedure was invented by interventional radiology about 50 years ago. It is no longer done by interventional radiology, but today, over the past 15, 20 years, we've had a huge technology explosion in our field. And so things that we used to just diagnose can now be treated. So things such as liver cancer, kidney cancer, lung cancer can all be treated very minimally invasively. And so half of my practice is interventional oncology, dealing with those kinds of tumors. And the other half of my practice is treating peripheral arterial disease, varicose veins, and anything dealing with a blood vessel. So when we speak about interventional radiology, liver-directed therapies, we're really talking about four main therapies. And those include radioembolization, which I'm going to focus on today, transarterial chemoembolization, drug-eluting bead chemoembolization, and radiofrequency or microwave embolization. We'll briefly touch on the latter three. Chemoembolization is really delivering very high-dose chemotherapy directly into the tumor, about 100 to 200 times the concentration of chemotherapy than what you would get through the IV. And this chemotherapy is deposited directly into the tumor, and you really limit the amount of side effects that you have from it because it's not circulating throughout the body. Drug-eluting beads is very similar, but the chemo comes wrapped in these little beads. Radiofrequency and microwave tumor ablation is really recommended for people who have maybe just one or two tumors that are about 3 centimeters or so in size. What's interesting is that this technology has advanced so much that in some cases, tumor ablation can be curative, and the results are almost similar to surgery. And this is really done on an outpatient basis, just with a little bit of numbing medication. We stick a needle into the tumor. The tumor is heated over 7 to 8 minutes. We're pretty much cooking the tumor under ultrasound or a CAT scan. Remove the needle, put a Band-Aid, patient goes home. Just wanted to stress the multidisciplinary approach to cancer that we have here at Penn, involving all these different specialties and the speakers that you heard today. Selective internal radiation therapy, or SIRT. This is what's called radioembolization, and this is a way to deliver yttrium, which is a sort of radiation, which is called a beta emitter. And what's interesting about yttrium is that it works at a very small distance, about 2.5 millimeters distance. So unlike some other types of radiation therapy, for example, iodine therapy for thyroid cancer, you don't have to stay away from family members or sleep in a different room. Once you get this therapy, you can really be interacting with everyone. But this therapy is a way to selectively target tumor cells with a very high radiation dose, but at the same time protecting the normal liver tissue. So this is an example of what the SIRT looks like. Just looks like a liquid. There's some very small little beads in there, and then that gets injected directly into the liver. And the purpose of doing this procedure is first to decrease the tumor burden in the liver, increase the time to progression. So hopefully we can halt the spread of the tumor. Hopefully we can also downstage the tumor. We can downsize it so a patient can perhaps undergo a surgery, a resection, or perhaps a transplant. And if patients are having a lot of symptoms from their tumors, we can help with that as well. So what is the typical SIR-Spheres patient, the radioembolization patient? Well, we're really looking at patients who are non-resectable or who have liver-dominant disease. They may have progressed on first-line chemotherapy and maybe have not responded to other lines of chemotherapy. They have a good performance status, and performance status really means it's a scale of how good your physical status is overall. Are you able to walk around and do your normal daily activities, or are you bedridden and really just can't get out of bed? So there's a scale that we use. What is your bilirubin? Bilirubin is a measure of your liver function. It sort of tells us how sick your liver is. So we sort of have a threshold for that, and that is 2. And then really, what is the overall survival? Do you have at least 3 to 6 months survival? Are you going to tolerate this procedure?
Selective internal radiation therapy, also known as SIRT or radioembolization, is performed using SIRSpheres microspheres. SIRT is a targeted treatment for inoperable liver tumors that delivers millions of radioactive microspheres directly to liver tumors. The implantation of microspheres takes advantage of the fact that the normal liver parenchyma is primarily supplied by the portal vein, while the hepatic artery is the primary blood supply for liver tumors. By using this preferential blood supply, tumors can be selectively irradiated, leaving healthy tissue relatively unaffected. SIRT is a minimally invasive therapy in which a transfemoral microcatheter is used to gain access to the hepatic artery supplying the liver. After mapping the hepatic arterial system and isolating the hepatic vasculature to prevent the deposition of microspheres in the gastrointestinal tract, the microcatheter is advanced into the position from which the microspheres will be delivered. The microspheres are administered through this catheter. Administration should be conducted in a slow and deliberate manner to reduce the likelihood of early stasis and retrograde blood flow. The SIRT procedure delivers beta radiation directly to liver tumors using the tumor's arterial blood supply. Microspheres are targeted directly at liver tumors via the hepatic artery, so exposure to the remaining healthy liver tissue is minimized. The microspheres average 32 microns in diameter, which is small enough to flow through the hepatic arteries, but are too large to pass through the capillary bed within the tumor, where they become permanently implanted in the tumor. The microspheres contain the radioactive element yttrium-90, which delivers beta radiation over a relatively short distance, an average of 2.5 millimeters in human tissue. Yttrium-90 has a half-life of 64.1 hours. Therefore, 94% of the administered radiation dose is delivered in 11 days, with almost no activity remaining after a month. Clinical studies show that when used in combination with chemotherapy, SIRSpheres microspheres can shrink patients' liver tumors more than chemotherapy alone, improve quality of life, and increase life expectancy. For a small number of patients, treatment can enable sufficient shrinkage of the liver tumors to permit future surgical resection.
Okay. So I think that video sort of captures what we're doing with radioembolization. This is just to show what an interventional radiology room looks like. Many people think of it as being an operating room, and to a certain extent it is, but the procedure is not done under general anesthesia. It's done under what we call conscious sedation. So if anyone has undergone a colonoscopy, you're sort of put in a twilight. But if we talk to you or call your name out loud, you will be able to respond. Most of this is done by us watching the video screen here. These are the major blood vessels of the body, and we're doing all of this through a little tiny puncture in the groin. So as far as some of the data shows, looking at a comparative retrospective data, overall survival, we had a study looking at 339 patients who underwent the SIRSpheres, and their median survival was 12 months. Now, this group was divided into 2 subgroups. We had patients who had metastatic colorectal cancer, and their median survival was 11.9 months. and then all others. So all others meaning people with breast cancer, pancreatic cancer, any other primary cancer, that was 12.7 months. And this was in comparison to standard care. Now, what we mean by standard care in these particular patients, these were patients who really were not responding to anything else. They had tried first, second, third line chemotherapy. Nothing else was really working. So this was an effort to try to improve their overall survival. This is an example of a 68-year-old male with metastatic colon cancer. Now, one of the things that I describe to my patients, when you're looking at the tumors, sometimes it can be very confusing. You know, if you happen to see your CAT scan or your MRI, it could be confusing as to what exactly are you looking at. And the easiest way for me to define that is, in general, when we undergo a CT or an MRI and we give a patient IV contrast, tumors that are alive will light up white with contrast. Tumors that are dead will look like a black hole. So when I see a patient, I tell them, here is your tumor, it looks whitish, and after treatment, I want to see a black hole, because that to me means that the tumor is dead. So here we have metastatic colon cancer. There's a large tumor here, here, and here. Now, it's not showing up as white, but it's sort of like a grayish white. And this is after radioembolization. You can see that we have these dark black holes here. So this is exactly what we want to see after radioembolization. This is a patient, a 78-year-old female with a metastatic neuroendocrine tumor. This is also treated with radioembolization, and you can see this patient has several tumors. We have this large one right here, all these white spots here. Those are all active liver tumors. This is an example during the procedure. If you can see this, this is a catheter, so it's like a straw that is going in the aorta, the main blood vessel of the body. And then we have a small catheter that goes into the liver and into the blood vessel that is feeding those tumors. This is after the radioembolization. This is about 2.5 months after the radioembolization. And you can see we have these large black holes here. So in conclusion, radioembolization is really an advanced, a minimally invasive therapy for primary and metastatic tumors. The main FDA indication for radioembolization right now is for primary liver cancer, which is hepatocellular carcinoma, as well as for metastatic colon cancer. Now, there are several other cancers that we will treat, such as pancreatic, GI malignancies, esophageal, and many times that's going to be up to the insurance. But we are also very proactive in working with the insurance companies to really fight for our patients and be advocates for them to make sure that they can get this treatment if it is needed for them. But one thing to keep in mind is that radioembolization does not work alone. You know, I could not do any of this work without my colleagues sitting here. And many times we have to put our heads together, and each of us has to bring our expertise to the table in order to treat patients. And then finally, Penn Interventional Radiology is sort of the birthplace of interventional oncology. There are really just a couple institutions that have the experience that we have with treating liver tumors from this particular method. Our institution, Johns Hopkins, Northwestern, are pretty much the three main institutions in the country that have the most experience with treating liver tumors.